Hi, my name is Dr. April Morrison. I'm graduate faculty member at the ETSU College of Nursing. Today I'm going to be talking about some pulmonary clinical pearls. I will be talking quickly. There's much to say and I only have 15 minutes to do it, so buckle up and hang on. Specifically, I'm going to be talking about pulmonary function test, or PFTs, and that right there is a patient with the technician who is actually doing the test right now. So what is a PFT? What exactly do? They actually measure the lung size. They determine airflow. So is there good airflow? Is there airflow obstruction? Is there airflow restriction? So those are all questions that this test will answer. It assesses lung function and actually compliance. So how well are your lungs actually working? If you do have a lung disease, it looks at the severity or the extent of the lung disease that you have. It also can look at progression of the disease that you're experiencing. In addition, we can use the results from this test to maybe modify our patient therapy, so maybe step up or step down on some of our medications. And again, it can differentiate between the restrictive versus obstructive airway disease, which can sometimes be difficult to differentiate based on patient presentation. So how do I know who needs PFTs ordered that day in the clinic? If someone comes to you and perhaps they're having cough, wheeze, shortness of breath, or maybe even crackles, that may be a good candidate. Particularly if someone has a history of smoking, maybe they've had a recent abnormal chest x-ray, maybe there's a connective tissue disorder and they're having some muscle concerns, because remember, the diaphragm is a muscle and that can impact their respiratory status. Maybe there's a neuromuscular disease. Perhaps someone now has ALS, and that is definitely going to impact their ability to breathe correctly. Maybe they're going to be having cardiothoracic surgery. Sometimes they will go send these patients for PFTs prior to their surgery. Again, maybe with an abdominal surgery, the same thing. And then an upper abdominal surgery as well. Lower versus upper. You want to make sure you get these on someone if they have a known pulmonary disease or you're currently trying to diagnose them today. So who does not need to be screened? And I have a little bubble here. It talks about, think about what is limiting that patient today. So in other words, what's going to limit that patient's ability to perform at their best? And is this procedure going to cause them harm in any way? So some of those things might be, maybe they've had an MI within the last month, so a heart attack. Perhaps they've got some unstable angina. They would not be a candidate. Perhaps they've had a recent cardiothoracic or an abdominal surgery. Again, they're not going to be at their best. Perhaps they've got some restriction because of pain or other things like that. If they've had a recent ophthalmologic surgery, we do not want to risk increasing that intraocular pressure. Again, if there's any type of a thoracic or abdominal aneurysm, we're going to be increasing the pressure that's going to be happening, and we don't want to risk a rupture. If they have a current pneumothorax, that patient will not be able to perform at their best. And then if they have an active respiratory infection, maybe they have TB, maybe they have pneumonia, again, that patient will not be at their best. Some things to think about, again, when ordering these tests is keep in mind that PFTs are effort dependent. In other words, can my patient understand what is being asked to be done? Is that patient able to sit still? So consider the age. This cute little girl down here in the corner, she looks to be about 2. She's probably not a candidate because, again, she does not really have the ability to participate adequately and to follow instructions. Is the patient hard of hearing? Because if they're hard of hearing, they're not going to be able to hear the instructions and we may get faulty results. Ultimately, you really want to try to consider patients greater than 6 for PFTs. Otherwise, children younger than that, they're really not going to be able to participate the way we need them to. So the actual procedure, the patient is going to be sitting in a chair, and we do this because we want to prevent the risk of having a syncopal episode, because there's going to be a lot of breathing, and oftentimes it'll be very, very rapid. The patient will have their feet flat on the floor. You really want to recommend that they not smoke for about an hour prior to the test, and you don't want them eating a large meal for about 2 hours prior to as well. The reason for that is, again, lots of heavy breathing, lots of things going on. We don't want that patient getting sick. Avoid tight-fitting clothes, so you don't want to wear anything that's restrictive. And then false teeth are actually allowed. And actually, if you look at some of the different places that do these, they may or may not permit them, but tell them to wear them to the visit. These tests will be performed 3 times. We want to make sure that the results are reproducible. So was this a fluke? Or maybe they didn't do their best that very first time. There's actually several things that can be done at a PFT test. Spirometry and flow volume curves and peak expiratory flow rates. Those are the main ones. Those are some of the ones we're going to be talking about today. They may do other things while you're there. Lung volumes, again, is also going to be calculated. Bronchodilator testing, so oftentimes they'll do this pre and post albuterol treatment to see how you respond to the albuterol therapy. And then you also look sometimes at diffusion capacity. The things we need to know to ensure we're getting these measurements correct is we need to know the patient's size. So how tall are they? Someone who's 6'6", like my brother, is going to have a much larger lung capacity than me, who's 5'11". So height is important. You need to know their age because lung function actually declines with age, and that is regardless of our smoking status. Gender, so a male is going to have a larger lung capacity than a female, so that's important to note too. Ethnicity is actually important as well. I didn't know this until preparing for this talk. However, white individuals actually have a larger lung capacity than those of blacks. And part of that has to do with the height of their diaphragm, the elevation of their navel, and there's actually a great article at the end of this in the reference page that actually touches on that just briefly. So, based on all of these elements, the height, age, gender, and ethnicity, all of those factors are used to create a normal or predictive distribution. So, for someone my age, my height, my gender, my ethnicity, what should I be able to do when I complete a PFT? And that is where we're going to be able to compare my numbers to what is the known normal. This is a brief video about a PFT. I don't know if it's going to let me play it or not. It doesn't look like it's going to, and that's okay. You can literally just go to YouTube, and there are some excellent resources there that show you how a PFT works. So you can just go to YouTube and type in PFTs. And there are many things that you can look at for yourself. So what are we looking at when we look at the actual PFT measurements? So we're looking at residual volumes. That is the amount of air that's left in the lungs. We're also looking at pulmonary diffusion, lung capacity, and we're going to look at these curves here in just a second. So it's going to be looking at the FEV1. FEV1, or the forced expiratory volume. This is how much air, how quickly and how hard I can blow out some air in 1 second. We're going to look at this curve in just a minute. We're also going to be looking at the forced vital capacity. So that is the maximum amount of air that can be expelled after a maximum inhalation. So in other words, I'm going to take in as much air as I can and blow out as much air as I possibly can. The number at the end of that is going to be my FVC. We can compare these two numbers, so however much air I can blow out in that first second versus what's happening at the end, we can actually look at that as a ratio. So we're going to divide the top number, our FEV1, divided by the bottom number. That gives us a ratio, and we can actually use that to help diagnose lung diseases. While you are there at the pulmonary function test, they may do an ABG, looking at your PaO2, your CO2, and oftentimes your pH. Depending on what's going on, they may do exercise testing to see how you're doing, and then they may also do what's called pulmonary compliance, and this is where they look at dispensability of the lungs when they're stiffened. So if you have decreased lung compliance, your results are going to look a little bit differently, and they can actually look at that specifically. Spirometry. This is the one you're going to use most frequently. And actually, you can purchase a PFT machine and keep it in your clinic, and you can do these all by yourself without ever having to send them. And you can actually use spirometry pretty easily because this is most oftentimes going to differentiate for you if there is an active pulmonary disease. So this looks at the volume of air over time, which we're going to look at a graph. It's looking at how much air can I take in, so my maximal inspiratory effort, versus the amount I can forcefully expel as long and as quickly as possible. And for an adult, that oftentimes is up to 10 seconds. So think about taking in that large bit of air, that maximal inspiration, and then forcefully, as hard and fast as you can, blowing out every ounce of air in your lungs for 10 seconds. That is very hard to do. So you can understand maybe why these patients need to be able to cooperate and really don't have any urgent medical conditions that are going on. Again, the FEV1, that's in that 1 second, and then we're looking at the forced vital capacity, and then we have a ratio. So those are the things that can be seen just doing spirometry. And spirometry is done when we do maximal inspiration followed by the forceful expelling of the air. Again, we look at this, and this will help identify, is this an obstructive disease or a restrictive disease? Less than 70% tells us that there is an obstruction. So if I'm performing at less than 70% of what someone based on my age, height, gender, and ethnicity is performing, that means I have a problem. Maybe I've got COPD, maybe I've got asthma. This is an example of a spirometry. If you look over here in the upper left-hand corner, this is what a normal spirometry would look at. So we have volume over time. The FEV1, you'll see the arrow pointing there. That is where we do our 1 second mark. All the way over to here to the very end, this is our FEVC or FEC. This is going to be the 10-second mark. For children, it's going to be a little less time. But you can see this awesome curve, lots of volume, and they can actually sustain that for a large period of time. Now, if we look over here at someone with an obstructive lung disease, so maybe there's air trapping, they cannot get the air out, you can see it's more of a flattened curve, and it actually will start to dip down towards the very end. A restrictive airway disease, they actually look more consistent, but this is maybe someone who's having diaphragm issues or muscle issues. They're actually looking very consistent, but it's just poor volume. When we look at flow volume curves, again, we're looking at maximal inspiration, and then we're going to do maximal expiration. And that is the whole time that they have the mouthpiece in their mouth. There's going to be on the graph, there's going to be a positive limb and there's going to be a negative limb. The positive one is the expiratory piece, and then the negative limb is the inspiratory piece. And then we're going to be looking at maximal flow rate, and that is going to be measured during expiration, and this is what's going to give us the peak expiratory flow rate. So I want to see how much air are they taking in versus how much are they pushing out. This is really, again, going to help us determine, is this a obstructive or restrictive. Oftentimes your obstructive is going to have a reduced expiratory flow, and we're going to look at the picture of that. Below here where you see my cursor, that is the inspiration. So the patient took in the air, and this is the expiration right there at the very top. So this is our positive or our negative. Kind of doesn't make sense, but this is going to be the inspiration right over here. This is the expiration. If you have somebody who has COPD, if you look here, their inspiratory volumes are not going to be that of what someone should be able to do who is their same demographic information. Again, expiration is going to be profoundly limited. One thing to note is there's a little bit of a kink here in the curve, and that actually is related to the obstruction itself. So that's kind of one of those telltale signs. If you see that on a volume curve, that kind of tells you, hey, I've got an obstructive disease of some kind going on with my patient. Total lung capacity. So this is the total amount of air in the lungs after maximal inspiration. So the patient's going to take as deep of a breath in as they can, release as much air out as they possibly can. You may see an increase in the total lung capacity if a patient has COPD, and again, that has to do with air trapping. And then it may be decreased in patients who have restrictive anomalies, because they're not going to be able to get the air out like someone else may be able to. So looking at restrictive versus obstruction, restrictive lung diseases, this means that their lungs have decreased compliance. So maybe they're hard, the lungs will begin to stiffen, maybe they're not able to expand their lungs like other people are able to do, maybe this person has kyphosis, ALS. Obstructive, this is increased resistance. So there's increased pressure needed to overcome that flow resistance, and so you're going to have a breath volume reduction. These things are like bronchitis, COPD, and asthma. What's the problem in asthma? We have airflow obstruction because of bronchoconstriction and edema. When you have these patients, sometimes you're going to see an FEV or FVC, that is going to remain between about 80 to 120. So it may actually look more normal, but you're going to see that ratio be decreased. So that's something to note, and that's going to be less than 70.7 or less than 70%. Other diseases, you're going to see a reduction in the FEV1 and FEC if someone has COPD, and